MedCram.com.
Welcome to another MedCram COVID-19 update. Today we're going to talk about Arcturus, which is the new variant that people are looking at specifically in India, but it's been around the world in 22 different countries, and it's been there for months, but it seems to be doing something a little bit more in India, and we're going to talk about that today. Omicron XBB.1.16 is its official name. And we're going to talk a little bit about whether or not this is of concern or not. So let's talk a little bit about this variant. As I mentioned, it has been found in India. We're going to show you some data on that. There is some increase in not only the cases in India, but also the amount of cases that are ascribed to Arcturus. It's also been found in the United States and in the UK and a number of other countries. In the US, specifically in California, Washington, New Jersey, New York, Virginia, and Texas. Good news is that we're not really seeing a change in the severity of the type of illness that this is causing. There is some data, and I'll link to that in the description below, that it may be about 1.2 times more infectious than the Kraken variant that we looked at a number of months ago. The symptoms are pretty much the same: cough, fever, sore throat. But a new one to add to the list seems to be happening more often with this one is conjunctivitis. So let's look at the data and see whether or not this concern is really founded or not, or whether or not we need to look at it a little bit more. But before I do, I just wanted to remind you again, if you're finding these videos helpful, please subscribe, give us a thumbs up, and more specifically, join us over at MedCram.com, where all of our videos are archived, in addition to great medical education videos. It's been a while since I posted, and part of that reason is we've been updating some of our videos. The most recent one that we've updated is the blood gas interpretation series, and I think that's a great series for a lot of healthcare providers who have difficulty with interpreting blood gas results. Head over to medcram.com and check us out over there. This is from Our World in Data, and what we're looking at here is specifically India. On the top row here, cases. And down here, we're looking at deaths. So when you look at data, always remember, check and make sure that the bottom number is 0, so they're not trying to fool you. Look at the scale here. In both of these cases, it's per million. Notice here that the top number is 250 per million, and here we're at 2.5 per million. What does that tell you? For every 100 cases, there's one death, generally speaking, in terms of the scale. It's not exactly, but you can see here that we're looking at a different scale. And we're looking here from the very beginning of the pandemic, so you can get a sense about how much is this rising by. And you can barely see, but if you look right here, you can see that baseline, which has been low for probably the longest since we've had the COVID pandemic. It's just starting to rise up a little bit. And it's even harder to see if there's any deaths. Let's zoom in so we can see this a little bit more carefully now. This is since February 5th of this year, and clearly we can see now that we've zoomed in that cases are going up, but they're at a case rate of 3.5 per million. We've got cases up in the top, we've got deaths down here. If it was about 1 to 100, we would expect that the number down here would be 3.5 divided by 100, or moving the decimal places over 2 places, or 0.03, and what we're actually seeing here is just 0.01. So we're not seeing the same rise in deaths, although remember, it could be that we're just a little bit delayed. So there is an increase in deaths, although it is more blunted than we would expect, and it looks a little bit higher here because of the way we've got the scale. Officially, they're saying that they're not seeing much of a rise in new deaths. Here, we're seeing a little bit of a rise. I think more time will tell. But what we need to do is put this in perspective of what these numbers would be if we were in the United States. So again, we're looking at cases per population. Now, India is a huge population, almost 1.5 billion. Compare that to 300 some million in the United States. So let's take a look at this if we bring in the United States, India, and even Canada in this situation. Again, we're looking at new cases per million, so this is population-based. Here is India way down here in terms of cases. And this is where the United States and Canada, respectively, have been up until this point. I think probably data has not come in here fully, but you can see here that the relative number of cases in India is well under what we're seeing here in North America. In terms of new deaths, very, very low here in India. You can see it's this purple line here along the bottom, as opposed to what we're seeing here in the United States and Canada. For clarification, the vaccination rate in the United States and India in terms of the first 2 shots are about the same, somewhere north of 60% of the population. So again, is this blip right here something worthy of our attention? It could very well be. It's something to definitely keep an eye on. This variant has been around in the United States and Canada and in Europe for some time, and it has not grown to prominence, and it has not increased the number of cases. So this is something that is unique to India, and I think we probably should keep an eye on it, but it's not a reason for alarm. In India, they are taking it very seriously, and in fact, in some cases, they are reinstituting mask mandates, and they are drilling healthcare providers and personnel in hospitals to be ready if there is a surge. And I think that's always a good idea to make sure that you're prepared if such a situation were to occur. I wanted to take this opportunity, though, to talk about our immune system and the T and B cell response in regards to cases versus hospitalization and death. And there was a great summary article that was published a couple of years ago in Scientific American. It went into great detail about things that we've known about the body's immune system for some time. And I wanted to give you a primer in terms of what that looked like and why is it that you can have a reduction in efficacy in terms of preventing cases, but not so much so in terms of hospitalizations and deaths. And what I'm going to do is I'm going to couple this in this presentation with recent data from various state departments of health in terms of the benefits of immunization against viruses, and even to this day, how they still may be holding up. Let's take a look at what happens with infection. So here we have SARS-CoV-2 infection, and we have macrophages, and the macrophages eat up the virus in terms of an infection. When it digests it, it takes those pieces and puts it onto the surface of the cells. And this is known as an antigen-presenting cell. And it presents that to B cells. Eventually, these B cells get to see these viral fragments. And whether or not this is the spike protein from the vaccine or the spike protein and the other proteins on the interior, like the nucleocapsid protein in an infection, the point is that the body makes B cells against these antigens, and these B cells are primed to make antibodies. Even though there's been a lot of attention made on antibodies during the pandemic, antibodies are simply one tool in the immune system's tool shed. We talked about an innate immune system, and we talked about using hydrotherapy and fever to increase interferon, which is something that the body can use in any type of viral infection, and it's not dependent on mutation. That's one arm of the immune system. Another arm is called the adaptive immune system, and antibodies are just one way that the adaptive part of the immune system has working against these viruses. What these antibodies are produced by are B cells. There are some B cells that will produce an exact, nicely fitting antibody against these proteins of the virus. So very tight antibodies that fit very nicely against these spike proteins. But if you can imagine, as time goes on and the virus mutates, these spike proteins are also going to mutate. And so these B cells that make these antibodies are not going to be as close fitting as they once were. And this would happen whether or not you were vaccinated or whether or not you got infected. This is going to happen because as the virus mutates, your own immune system is going to have B cells that used to fit tightly against this spike protein, but doesn't as much now because of mutations. When these B cells are made with these nice, tightly fitting antibodies, there's also a subsection of other B cells that make antibodies that are more loosely fitting. So these antibodies can be produced and they don't fit as well, but the body still keeps them around. And as it turns out, these antibodies can sometimes fit more tightly on spike proteins that have mutated. So in other words, the response from B cells in terms of antibodies is not a very tight-fitting antibody only, but rather a distribution of antibodies, sometimes that can actually attack these spike proteins, even though they look slightly different. It's a broad response, in other words. So we talked about the virus when it comes into the body. Let's talk about when the virus actually infects a regular cell, and now the body has to go eliminate that cell. That's one of the big issues in SARS-CoV-2 infection, if you remember, because this is what sends people to the hospital. They become infected, and after about a week, they start to decompensate. And that's because the T cell response is so hyper. It causes so much inflammation that the patients have fluid fill up in their lungs and things of that nature. What is going on there, again, here is the virus coming in, and it infects on the receptor of the cell. And what happens is that the virus goes inside, and it gets chopped up by the cell. Sometimes it reproduces, other times it gets chopped up. And there is a protein that gets placed on these particles that is related to the major histocompatibility complex class 1, which signals CD8 T cells. Go to the surface like this, and then these killer T cells or cytotoxic T cells comes in and docks with these proteins and recognizes these viral protein fragments. This type of response, the T cell response, is even more broad than the B cell response. And more importantly, notice how here you have a spike protein here you have a spike protein here, but here you have proteins that are not externally visible. In other words, other proteins that are part of the virus that may not make up the spike protein and may not mutate, even though there is spike proteins here. The response from these cytotoxic T cells is broad enough so that, and here's the key point, mutations in the spike protein generally will not affect largely the T cell response. And it is the T cell response that is important for preventing hospitalization and death. Let me rephrase that in a different way. If the virus were to mutate, as it has been, because of this mechanism of T cells, we would not expect that spike protein mutation, which is where a lot of the mutations are occurring, to really affect the ability of either previous infection or vaccination to affect hospitalization or death. And I think that's the reason why, even though we're seeing infections, even though we're seeing variants, we're not seeing the huge surge in hospitalizations and deaths that we once were. Let me show you some notes from this Scientific American article in talking about B cells. This phenomenon where there's extra B cells that have these antibodies that don't fit as tightly can be explained by a process called somatic hypermutation. It's one of these reasons that your immune system can make up to 1 quintillion distinct antibodies, despite the human genome only having 20,000 or so genes. So for months and years after an infection, memory B cells, the ones that make antibodies, hang out in the lymph nodes, and their genes that code for antibodies acquire mutations. So this is really cool. These antibodies are formed as a result of the genome of the B cells. And if the genome in the B cells are mutating, then they also mutate in a way that would anticipate or capture the mutation of the virus. They say here that the mutations result in more diverse array of antibodies with slightly different configurations. Cells that make antibodies that are very good at neutralizing the original virus become the immune system's main line of defense. But cells that make antibodies with slightly different shapes, these ones that are the minor ones that do not grip the invading pathogen so firmly, are kept around too. Let's say you developed another COVID infection and it was different than the first one that you had. It's not as if you're seeing this virus for the first time. You have B cells that have mutated in anticipation of the new virus and its new spike protein. Let's talk about T cells, because they talk about that in this article as well. They say here, escape from serious COVID could also be aided by another line of immune system defenses, T cells. These cells do not go after pathogens directly, but a subclass of them seek out infected cells, as we talked about earlier, and destroy them. Immunologists say that T cells have a somewhat broad brush approach to recognizing pathogens. They respond to fragments from various parts of the virus, unlike the highly spike-specific nature of B cells, and this makes them less likely to be fooled by variant shape shifting, which generally is occurring in the spike protein. And they talk about this study that was released a couple years ago and actually has been peer-reviewed and published from Crotty and Seti that showed that T cells from people who had been exposed to SARS-CoV-2, either naturally or through vaccination, their T cell response was not dampened by the variants. So this is really key here because it's the T cell response that determines generally hospitalization and mortality. Study says that while a weakened B-cell response could let the virus in and get a foothold, it's plausible that T-cell activity will keep it from running rampant through the body. In a scenario where infection is not prevented, you could have T-cell response that would modulate the severity of the infection. So this is something that they thought about a couple of years ago. There's been a lot of data. They know the immune system fairly well to be able to publish this. And in fact, their publications has actually shown this. Let's take a look at some real-life data. And for that, we're going to go to the state of Utah. This is not from the CDC or the FDA or the WHO. This is real-world state data from their public health department. And again, we're looking here at data since September 15th, so that's the last 6 months. So this is all exclusively Omicron. This is many generations away from the original Wuhan variant. You can see here that we're looking at unvaccinated, fully vaccinated, so that's going to be the 2 doses. And we're looking at the bivalent boosted. And we're specifically looking at cases, hospitalizations, and deaths. And remember what we said about hospitalizations and deaths? This has to do with T cells. And cases, this is infections. This is the first line of defense, which is the innate immune system. And of course, antibodies, which help to prevent infections, if you can get that. Here we're looking at unvaccinated, and you can see here that when we compare unvaccinated to fully vaccinated, there's a 1.4 greater risk of testing positive for COVID-19 than fully vaccinated people. That means just 2 doses. So even with Omicron, even with the newest variant, when you have seen a spike protein that is similar but not the same, because the B cells are able to mutate in some way, there is still, albeit smaller than there used to be, there is still a reduction in the number of cases. The other thing that I would add about this is that in the definition of unvaccinated, that means that they've never received a dose of the vaccine, versus fully vaccinated. They have to wait either a week or 2 weeks after their second dose to say that they're fully vaccinated. And remember now, we're talking, this is September 15th of 2022, so we're way past where the majority of these people who've been vaccinated have gotten their vaccine. Most of these people got their vaccine years ago. And so in this time period from September 15th to current, those 2-week intervals are pretty much non-existent for the majority of this population that we're looking at. This is Utah specifically, and we're looking at people who have had the initial COVID vaccine protocol, so that's 2 doses if we're talking about the mRNA, and 1 dose if we're talking about the Johnson & Johnson. And literally since this time, this is the amount of people who have had that series of 2 doses. So for the majority, for the rest of the people that we're looking at, during this period of time, they were not vaccinated. They began this cohort already vaccinated. So the 2-week period is non-existent in terms of an argument in this situation. The next thing I want to draw your attention to is the reduction in hospitalizations and the reduction in deaths when we're talking about just the 2 doses of the mRNA or 1 dose of the Johnson & Johnson. You can see here that here we're looking at T cells. And because there is this very broad immunity that is developed, regardless of the variants, you can see here that hospitalizations and deaths are way down, even further than cases. So it's always important when people are talking about the effect of SARS-CoV-2, whether or not they're talking about cases or whether you're talking about hospitalizations and deaths, because the T cells are holding up fairly well, even when we're talking about the original dosing schedule. This is the same situation that you're going to see with previous infection. You're going to have the same situation, a very broad coverage of T cells and a very broad coverage of B cells, but with T cells being even more broad than just the B cell response. This data is also interesting in terms of the bivalent, which is a little bit beyond the scope of this topic, but you can see here that in terms of cases, there was a modest reduction in terms of preventing infection between the cases. And one of the arguments could very well be by the time they had the bivalent that came out, the virus had already changed by that point again. In terms of cases, we're not going to always be right on the next variant to prevent infections. I think that's something that we have to just recognize. There is a reduction. There is some efficacy. Even in the oldest vaccine, there's a reduction in cases, but I don't think we're going to get that down to a number that we would see in the clinical trials where we're dealing with the same variant. However, different story when it comes to hospitalizations and deaths. In terms of preventing the worst outcomes of COVID-19, either vaccine or previous infection is going to show very good T-cell immunity. And that, because of the broad range of T-cell immunity in patients, is going to prevent the worst outcomes. As the unvaccinated population becomes more and more infected, what you're going to see is probably a diminishing of the differences between the unvaccinated population and the vaccinated population. Because of the fact that those in the unvaccinated population become infected eventually, you're going to see the immune system acting very similarly in both populations. And as we've seen over the last couple of years, these numbers come down from 20-fold, 15-fold to numbers that we're seeing here. Although surprisingly, we're still seeing a difference even in the large amounts of infections that we've seen in these states. And so as the benefits of new vaccination and new boosters change, that's going to have to enter into the overall equation that we use in terms of risk versus benefit. And I could see it very easily coming to a sense of what we see for the flu, where we don't recommend booster shots during the summer, but predominantly during the winter, as we've seen actually in Switzerland recently, where they have said that they are not recommending booster shots or vaccination during the spring and summer, but they're leaving that open to decide what happens in the wintertime. And for those of you that are interested, the website at the Utah Public Health Department also does age group stratification, and you can see here the different age groups for cases, for hospitalizations, and for deaths. So based on all of that information, you can see why I think we need to be calm and be circumspect and to look at what it is that's going on. Not panic, and look at the number of cases that are going on in India, the paucity of deaths, although we need to keep an open mind to that and make sure that we're not missing something, and realize that our immune system have built-in mechanisms that will take care of these variants. Of course, if you are someone that has comorbidities, then you want to make sure that you're talking with your physician and assessing your individual risk. But the purpose of this video was to educate you on your immune system and some of the built-in mechanisms that it has to deal with variants such as this variant. As always, if you like this video, give us a thumbs up, subscribe, and join us at medcram.com. Thanks for joining us.